Okay, so this is part 2.4. I hope I cover everything in this part 2.4. If not, I might need to go to 2.5 if my energy does not permit. And in this part 2.4, the first topic is Turner syndrome. So the question had all the features of Turner syndrome, and the options had what would you find in what cardiac abnormality would you find in this patient. And so the features of Turner syndrome are the patient has a short stature and webbing of neck, low posterior hairline, broad chest and widely spaced nipples. This is very important because that was in the question, the webbed neck and the broad chest and widely spaced nipples. Cubitus valgus, pigmented navy, streak ovaries, infertility, amenorrhea. Streak ovaries, infertility, amenorrhea. Why does Turner syndrome happens is 45X, and there is absence of one chromosome, X chromosome. So there's streak ovaries, infertility, amenorrhea, and peripheral lymphedema at birth. So these are the features of Turner syndrome, and the cardiac abnormalities you would find in this patient is coarctation of aorta and bicuspid aortic valve. Bicuspid aortic valve and coarctation of aorta. So more about Turner syndrome is that the cardiovascular abnormalities are more life-threatening in Turner syndrome, and left side cardiac abnormality is most common. Coarctation plus aortic valve disease plus hypertension. If all these three are present, then there is risk of aortic root dilation, which can progress to aortic dissection or rupture. So coarctation of aorta, aortic valve disease and hypertension, if all these three are present in this Turner syndrome patient, then the risk of aortic dilation, there is a risk of aortic dilation which then can lead to aortic dissection or rupture. And other option was, it was like other option had cardiovascular defects which were seen in Down syndrome. So commonly seen cardiovascular abnormalities in Down syndrome is atrioventricular canal defects. This results from abnormal endocardial cushion development. So commonly seen cardiovascular abnormalities in Down syndrome is atrioventricular canal defects, which is a result of abnormal endocardial cushion development, and this also include anomalies of atrioventricular valves as well as atrial and ventricular septal defects. So anything involving atrium and ventricle, the valves are due to the abnormal endocardial cushion development, and you see this in Down syndrome. The other features of Down syndrome is that which are very obvious: epicanthal folds, upslanting palpable fissures in the eyes, small low set ears, flat facial profile, short neck with excess skin, furrowed tongue, sandal toe deformity, like this is if this is the toe, then the sandal toe deformity, and hypoplastic incurved fifth finger. So the fifth finger will be curved, and you also see single transverse palmar. This crease is single transverse palmar crease. So these are some features of Down syndrome. Yeah, one thing I missed is brush field spots in the eyes, especially in the eye pupils. Sorry, not the pupils, in the eyes, brush field spots. And Marfan syndrome and Ecker syndrome are connective tissue disorder, and the most common cardiac abnormality in DiGeorge syndrome is tetralogy of Fallot. So the next topic is differentiating unstable angina and NSTEMI. NSTEMI we studied in part 1. I'm not going to go over it again, but differentiating unstable angina and NSTEMI is that increased troponin level within 6 to 12 hours in NSTEMI. You can see increased troponin level within 6 to 12 hours in NSTEMI, but the acute management is same for both NSTEMI and angina. And other option was STEMI, but I don't remember the question very well. So the percutaneous, this is something we studied earlier as well. If percutaneous intervention, the revascularization cannot be done in 24 hours, then IV alteplase is given. It is a tissue plasminogen activator, fibrinolytic. It is a fibrinolytic drug, tissue plasminogen activator. And if the percutaneous intervention cannot be done in 24 hours, then we give IV alteplase, and alteplase is not indicated in STEMI. This is in STEMI. Alteplase is in STEMI. The next one is an interesting case of pericarditis. So we read most of the features about pericarditis earlier. However, this pericarditis is due to uremia. So unlike other pericarditis, pericarditis due to uremia doesn't cause diffuse ST elevation or P-wave depression. Initiation of dialysis is indicated, and that resolves most of the symptoms. In 50% of the cases of uremic pericarditis are accompanied by pleural effusion. Pericardial effusion, not pleural effusion. 50% of uremic pericarditis patients have pericardial effusion. So cardiac tamponade must be ruled out before initiating dialysis. And another thing I have noted here is acute coronary syndrome does not have pleuritic chest pain. Maybe the question mentioned pleuritic chest pain, and to rule out acute coronary syndrome and go for the right option of uremic, the patient had increased uremic profile. So yeah, acute coronary syndrome doesn't have pleuritic chest pain. And also the other option, another option was viral pleurisy. Viral pleurisy is inflammation of lung pleura that also has friction rub like pericarditis, but it is differentiated by auscultating and asking the patient to hold the breath, and this the rub will disappear, the pericardial rub will disappear. That is viral pleurisy. So the next topic is exertional syncope. The underlying pathological causes of exertional syncope could be ventricular arrhythmia due to MIR infarction, the outflow tract obstruction. This is the most common cause, I believe, because in most questions I saw. The examples of outflow obstruction could be aortic stenosis or hypertrophic cardiomyopathy. Clinical presentation of these patients are progressive dyspnea on exertion. Fatigue, exertional fatigue. So how this happens is there is a fixed outflow obstruction in cases like severe aortic stenosis. Cannot increase cardiac outflow because there is obstruction in response to exercise-induced vasodilation, leads to decreased BP. In exercise, there is vasodilation due to exercise, but the cardiac outflow cannot be increased. This leads to decreased BP that causes transient cerebral perfusion, decreased exercise tolerance, and pre-syncope or syncope. So patient with exertional syncope, we should suspect this ventricular arrhythmia due to MIR infection, but that will be like very acute, and outflow tract obstruction. And in aortic stenosis, there is decreased exercise tolerance, exertional syncope, angina, or syncope. I have written it multiple times. And a few other important points to note about this syncope is about the syncope is from the other options. I have noted down a few important points. There is prominent capillary pulsation in fingertips or nail beds seen in aortic regurgitation. Prominent capillary pulsation in fingertips and nail beds that is seen in aortic regurgitation. Aortic regurgitation present with progressive dyspnea or fatigue, but there is no exertional syncope. That's how, if there is no exertional syncope, it cannot be, if there is exertional syncope, it cannot be aortic regurgitation, right? Aortic regurgitation, only regurgitation is there, but anyway the blood is gonna flow and there is not going to be low cerebral perfusion or anything, so there is no exertional syncope. Prominent capillary pulsation in fingertips or nail beds seen in aortic regurgitation, maybe due to the regurgitation in the aorta, the capillaries, it transfers to the vessels and you see these capillary pulsations. And in pulsus paradoxus, you see exaggerated decrease in systolic BP during inspiration. In pulsus paradoxus, there is exaggerated more than 10 mmHg decrease in during inspiration. And in orthostatic postural hypertension, decrease in systolic BP by more than 20 mmHg or diastolic BP more than 20 mmHg within 2 to 5 minutes of standing from a supine position, and they also don't have exertional syncope. So if the patient has exertional syncope, we can confidently rule out, to pick the answer, confidently rule out aortic regurgitation and orthostatic hypotension, postural hypotension. Okay. So the next topic is cardiac stress test. We already saw how do we, what do we do during the chest pain, which is called evaluation of chest pain. This is just an overview of type of stress and type of stress test and what are the indications and not to be done in which patients. So the types of stress tests are exercise ECG, pharmacological stress test with adenosine and dipyridamole or dipyridamole, and dobutamine stress echocardiography. So the exercise ECG, how the mechanism of this is increased heart rate and increased BP. This is best for patient able to reach total heart rate, THR. Total heart rate is equal to 85% of 220 minus age. If this is the patient is able to reach this THR is equal to 85% of 220 minus age, then you can use exercise ECG. This exercise ECG cannot be done in left bundle branch block if the patient has pacemaker, patient unable to reach THR. Then we come to the next one. If the patient would be suitable for pharmacological stress test with adenosine or dipyridamole. The mechanism of this is the non-selective adenosine agonist dilates coronary arteries. The non-selective adenosine agonist dilates coronary artery. This can be done in whatever, not for exercise ECG. If the patient has left bundle branch block, pacemaker, patient unable to reach THR, this pharmacologic stress test can be done. But pharmacologic stress test cannot be done in reactive airway disease, patients on dipyridamole or theophylline. They are already on vasodilators. This cannot be done. So for them, we go to dobutamine stress echocardiography. So the mechanism is, it is a B1 agonist. It increases heart rate with or without increasing the BP. Dobutamine stress echocardiography. This is a B1, dobutamine is a B1 agonist and that increases the heart rate with or without increasing the BP. This is done in patient who have reactive airway disease, patient unable to reach THR, and it is not indicated in patients with tachyarrhythmias. So I have written little notes about adenosine pharmacology. So adenosine is a class 5 arrhythmic. Its effect of vasodilation is by acting on the A2 receptors, and it also acts on A1 receptors, and that causes atrioventricular block transiently. So it is used in paroxysmal supraventricular tachycardia or AV node reentrant tachycardia. To the first line of management in these two cases, adenosine, is paroxysmal supraventricular tachycardia and AV nodal reentrant tachycardia. Diagnosis of supraventricular tachycardia versus ventricular tachycardia is also made by using adenosine because it acts on AV node and it blocks the AV node transiently, hyperpolarizes it, and it blocks the AV node transiently, which helps us to see if the tachycardia is supraventricular or ventricular. And yeah, so when we give adenosine, the normal coronary arteries dilates, but the arteries which are affected will not dilate. So we can use that in cardiac stress test for our benefit. Why it cannot dilate the diseased arteries and only dilates the normal artery is that the diseased arteries are already dilated to the max by the sclerosis and also for compensation. So it does not dilate the diseased arteries. It only dilates the normal arteries. And also it is very short acting, and it should be like its half-life is with lesser than 10 seconds, and it is given with an IV flush. The other thing I have noted here is MI can lead to cardiogenic shock, of course, and it is again very, very, very important to know the hemodynamics of all types of shock. I studied something about pulsus paradoxus, which is decrease in systolic BP, decrease in systolic BP by more than 10 mmHg in during inspiration. The topic here now is pulsus paradoxus. As I said, during inspiration the systolic BP is high, and during expiration the systolic BP is low. This repeats every cycle, and the drop should be more than 10 mmHg for the diagnosis. Pulsus paradoxus is seen in cardiac tamponade. Classic sign of cardiac tamponade is pulsus paradoxus. Severe asthma, COPD, exacerbation, constrictive pneumothorax, but it is very less common in pulsus paradoxus, less common in constrictive pneumothorax, and it is also pulsus paradoxus is also seen in tension pneumothorax. So why this pulsus paradoxus happen in all these conditions is by various mechanisms. They somehow push the right ventricle towards the left ventricle, and the left ventricle outflow is lesser. This causes the decrease in systolic BP. Next topic is alcoholic cardiomyopathy. These patients present, usually they don't have coronary artery disease, no valvular disease in alcohol abuse patients. And the degree of left ventricle dysfunction in alcoholic cardiomyopathy is directly related to the daily amount and overall duration of alcohol intake. The mechanism how this cardiomyopathy happens in alcohol abuse is alcohol is direct myocardial toxin, mitochondrial injury in cardiac cells. So there is myofiber loss, ventricular dilation, decreased contractility, systolic heart failure. So that's about alcoholic cardiomyopathy. And the next topic is coarctation of aorta in adults. So the causes are congenital, and sometimes it can be occurred, for example, in Takayasu arteries. The clinical features are upper body is well developed, and also there is hypertension in the upper body. Like they also present with headache and epistaxis. And lower extremities are underdeveloped. They have claudication, the pain and other things in the lower extremities. Brachial femoral pulse delay, and upper and lower extremity BP differs. And left intercost, you hear a continuous murmur in systolic or continuous murmur in left interscapular region. In the interscapular region, you see systolic or continuous murmur. You hear the diagnosis. ECG shows left ventricle hypertrophy. Chest X-ray, it is a chest X-ray has inferior notching of 3rd to 8th ribs. It is due to bony erosion. Inferior notching is nothing but bony erosion, and it is due to enlarged intercostal arteries, because the there is a constriction, and these vessels are enlarged, and that causes bony erosion. And the classical sign of coarctation of aorta in X-ray is 3 sign. Due to aortic indentation. The diagnosis confirmation is by echo. So the other important key points from the options in this question was prominent right atrial contour. It's seen in Epstein congenital anomaly, which is nothing but apical displacement of tricuspid wall, thereby atrializing the right ventricle. Other option is transthoracic echo can assess for segmental wall motion abnormalities during an episode of chest pain or after exercise. This is helpful in diagnosing Takotsubo cardiomyopathy. Takotsubo cardiomyopathy. We studied something similar, Takayas to arteries in coarctation of aorta in adults. And the next topic is cardiac myxoma. So it is a benign neoplasm. 80% of the time it is located in left atrium, and the clinical feature is that the position dependent mitral valve obstruction. The position dependent mitral valve obstruction, you hear a tumor plop sound at the end of diastole, and you hear a mid diastolic murmur as well, because during the diastole the ventricles are filling, and if the mass is obstructing the mitral valve, then you hear a mid diastolic murmur. This murmur mimics mitral stenosis. And the other clinical features are dyspnea, lightheadedness, syncope, embolization of tumor fragments, and this can cause stroke, and the patient had left hemiparesis in this question. And constitutional symptoms, weight loss, fever, and all that. Diagnosis is by echo, and management is prompt surgical resection. Differential diagnosis is infective endocarditis. Echo shows valvular vegetation, not mass. If it's a mass, it could be cardiac myxoma. And the next topic is sustained monomorphic VT. The diagnosis is wide complex tachycardia with 2 fusion beats. Wide complex tachycardia with 2 fusion beats. And what does this sustained means is that it occurs for more than 30 seconds, and monomorphic is that all QRS complex looks the same in contrast to ventricular tachycardia or other tachycardias. And the key point here is the ECG strip was given, and the QRS complex all looked same and were wide, and you can clearly see the fusion beats in there. And the risk factors for which can cause sustained monomorphic VT is cardiac coronary artery disease, left ventricle systolic dysfunction. But these risk factors are not just for sustained monomorphic VT, but for all ventricular arrhythmias, VT, VF, ventricular tachycardia, ventricular fibrillation. Management depends on the symptoms and hemodynamic status. If the patient is clinically stable, it is managed with antiarrhythmic drugs. IV amiodarone is usually preferred. IV amiodarone is usually preferred. If the patient is not responding to IV amiodarone, then procainamide, sotalol, or lidocaine given. If the patient is unstable, then synchronized cardioversion is done. So the ECG strip was given, and we were asked to select the next step of management. The patient was hemodynamically stable, and there was synchronized cardioversion in the options as well, along with IV amiodarone. And as the patient was hemodynamically stable in the question, IV amiodarone was the right option. But other options were carotid sinus massage. It is used in paroxysmal supraventricular tachycardia. It is a useful maneuver to get paroxysmal supraventricular tachycardia in control. And in the ECG, you see regular narrow complex tachycardia. There is no fusion beats. So what to do in patients with persistent tachyarrhythmia with severe symptoms like altered mental state, acute heart failure, or pulmonary edema, ischemic chest pain, or other severely symptomatic like hemodynamically unstable with hypotension, signs of shock, that is immediately managed with a synchronized electrical cardioversion. And patients with VF or pulseless VT should be managed with immediate defibrillation. Defibrillation is nothing but unsynchronized cardioversion. And one another option was esmolol. Esmolol is an ultra short acting beta blocker used for rapid rate control in atrial flutter or atrial fibrillation. Okay, so this is the next topic is cyanide toxicity. The patient had hypertension, and his hypertension was being managed by IV nitroprusside, and the options had alcohol withdrawal symptoms, and if it is due to the management of hypertension, like the BP is got in control much quicker than the guidelines of how much BP should be decreased. So before that, the cyanide toxicity occurs in patient receiving prolonged infusion or higher doses of nitroprusside for hypertension, and is most common in patients with renal insufficiency. The characteristics of cyanide toxicity is altered mental status, lactic acidosis, seizure, coma. Altered mental status, lactic acidosis, seizure, and coma. And as the question had a patient with seizure, and the option had alcohol withdrawal. So usually in alcohol withdrawal, the alcohol withdrawal peaks at second day, and that's where you see the seizures. Seizures between 12 to 48 hours of alcohol withdrawal. And hypertensive emergencies, mean arterial pressure is lowered by 10 to 20% in first hour, another 5 to 50% over 23 hours, over the next 23 hours. 10 to 20% in first hour, and another 5 to 15% in over the next 23 hours. 10 to 20, 5 to 15. And excessive pressure drop can cause cerebral ischemia, altered mental state, or generalized seizures. But this patient's BP was managed according to the guidelines, and I have to remember the numbers. 10 to 20, 5 to 15. 10 to 20% in the first hour, 5 to 15% over the next 23 hours. And this concludes the part 2.4 as well as the part 2 of cardiology. And I am planning to revise cardiology part 1 after this, and then go to part 3. So that's it, and I got that's it, and I hope we all pass the exam. Thank you. Peace.